I think it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I'm the CEO and founder of the Global Liver Institute, and I have the great privilege of being your host for this special episode, this special series of GLI Live, as we celebrate, as we highlight issues for Pediatric and Rare Liver Diseases Month, something that even within the liver diseases community or the liver health community does not get enough attention. As much as we are now understanding about the struggles of having healthy births, healthy moms and babies in the United States, particularly for women of color, we know that our colleagues around the world have additional challenges. And so we will be diving into those today, discussing the global health needs assessment in maternal and neonatal care. And with me, I have back someone who is now a favorite of the GLI family, Dr. Mbianke Livancliff. Welcome. He is a hepatologist, NCD researcher, Bosch Alumni Fellow, and CEO of the Empower Women Foundation, coming to us from Cameroon. Also, we have Madame Nasah Judith Lainsi, who is also an NCD researcher and an expert in maternal and fetal health. And we have from Salerno, Italy, Dr. Pietro Vajro. He is chairman of pediatrics at the University of Salerno and one of our favorite pediatric gastroenterologists, hepatologists. For many of you who've been following the show, you know my husband is also a pediatrician, and so they are very special to me. Welcome to you all.
Thank you very much, Donna. It's a pleasure to be here.
Thank you. So why don't we start with you, Dr. Livancliff, and you tell us about the work that you're doing in Cameroon, and particularly the challenges for patients with rare disease and pregnancies in liver patients, something that they don't think that we have and do, but we do.
Definitely, Donna. I think when I was getting set for this show, and when I went through what we'll be discussing, it was very interesting because I think my setting, it's very peculiar. What we have done over the years about liver health is more about research, sensitization, and raising awareness. Because the first challenge we face within our context is that there is that lack of awareness and that lack of public concern about liver health. And that is a gross challenge. And when we are looking into it, we realize that the lack of public health concern and traction is because of the lack of availability of data. There is no data to drive public health traction. There is no data to raise the burden of liver health within the context of Cameroon. And I think it may be similar to most African settings, especially lower middle income countries. And those are the specific challenges for pediatric and for neonatal health. The specific challenges we face is in diagnosis. When we're doing our need assessment, we realize that the first thing, pediatricians are not equipped with the required knowledge and equipment to actually diagnose liver diseases. And as a result, most of these conditions go unnoticed, undiagnosed, and are attributed to something else. For example, how do we properly diagnose something like Alagille syndrome or something like biliary atresia? It's still a mystery within the context of Cameroon. So as a result, most of these diseases are undiagnosed and are not even known within our context. Like, for example, in the case of pregnant women as well, for women with acute fatty liver of pregnancy, these are diseases that goes unnoticed. and they are attributed to something else, to witchcraft, which is the most common attributor to the cause of complications and death, because we don't have enough capacity to actually diagnose, and we don't have enough data to actually raise the concern of these diseases that are challenging our communities. And I think let me just share with you a report that was done for just few samples that were collected for pregnant women. It may shock you. I think this was a research that was done in 2020 by a researcher in Uganda. It was under a project. I don't know if I can remember the name. They selected a few pregnant women to actually follow them up for a period of 6 months. Mm-hmm. So the women that had symptoms of acute fatty liver, of pregnancy, their samples were collected and they sent out of the country. Some of them were flown out of the country for ultrasound, for more investigative, for more investigations. And within that few samples that were collected, within that small sample size, it was amazing of the number of them that were diagnosed with acute fatty liver of pregnancy, and it was very worrisome. But now, where has this research gone to? Since it is just in a low scale with a lower sample size, the decision makers don't find it worrisome. They feel like it is not representative enough. So these are the challenges, and most of our work has been, let's raise awareness, keep pushing the awareness level in across the different personas, in schools, in our universities, in our workforce, medical doctors, specialists, internists. And the big challenge is, how do we get data that can back what we are saying? That is a big challenge we are facing in our context.
And I'm sure I hear so much need for that data, because so many of the registries lack representation, whether it's genetic samples or phenotypic data or just other data from African or people of African descent. And so we want to be that bridge between the work that you're trying to do and your relationships with people, with patients, and that data, and the needs to diversify the larger data pools. I want to bring this back though to the patients and to the people, to the women. Dr. Lainsi, what do women and families in your community, what issues do they raise with you? Are they aware of liver disease? If they get a diagnosis of a liver disease while they're pregnant or with their child, is it shocking to them? Tell us more about that.
Thank you. Indeed, in area of liver disease challenges, the challenges that are faced to receive care. The first area he said was diagnosis. And I want to add in this area that most of the liver disease is lack of awareness, just as he has said. And most at the care level, the facility, most people go to the primary care facilities, and they don't, since they are not aware of the impact of liver disease, they don't even prescribe it. They don't even have it as a package to start screening. Most of the time, since the symptoms almost appear like malaria, they only treat malaria and treat before it progresses to another thing. And so since the test equally is expensive, most of the times the doctors don't prescribe it at all. So many persons come to their hospital, many children, and they go unnoticed without having any diagnosis. It is only when a doctor has seen that this child has maybe a condition that looks at times, it is not part of the test that should be run. Firstly, because of the cost, and secondly, because of lack of awareness about liver diseases, about the impact of liver disease in the community. I want to say that we just finished a brief test. This is among the adults. and within 25 tests, we have about 3 persons who are positive. These 3 persons don't even know about the situation. They're living their health, they're fine, but there is a problem that they don't know. And if an awareness is not raised, they will not even do the test. Less campaigns are made concerning liver disease. And so people don't take it into consideration to see that they can manage it. And most people who are coming up for it are already at the chronic stage where management becomes difficult and quite expensive. So for in the pediatrics, somehow by 2005, since I read one report that was carried out in Southwest in one community, the prevalence of hepatitis was quite high among pediatrics equally. And so since that was early before 2005, and since then, since the problem was there, most children these days are now vaccinated with hepatitis, most babies. And so one study that was done done in Yaoundé in the pediatric children less than 15 years, about 83 participants were included, and then 60% were vaccinated. Out of those who are not vaccinated, they were having about 5% had liver disease. They were tested positive for hepatitis. So lack of awareness is a major problem in our community, that if awareness is created, we are sure that many people will be tested. And also poverty. Most of those who are affected are those who live.
We may be losing the signal, so why don't we come back to you and hope that the signal comes back. Madam Nancy, we're going to come back to you when your signal comes back a little stronger for you to finish that excellent thought. And we'll come to you, Dr. Vajro.
They don't say hi. Awareness. Okay.
Okay. All right. Thank you. Dr. Vajro, for most people don't even think that children get liver disease. So why is there a need for pediatric hepatology? Is perhaps where I'll start. Tell us about how liver disease does in fact manifest in infants and children. You're still muted.
Okay. First of all, thank you to everybody for having invited me to share some knowledge in pediatric hepatology. Well, I live in Italy, but I have been trained in France with Professor Alagil. I have been one of his chef of the clinical assistant, and the United States, San Francisco, with a group of scientists working on neonatal jaundice. So when I was young, I already was very passionate with pediatric liver disorders. Now, well, I am recently retired from my full professor of pediatrics position and pediatric hepatologist, but I am still collaborating with the European Society of Pediatric Gastroenterology, Hepatology and Nutrition, and with the Italian Society, and with so many journals devoted to the pediatric liver disorders. Well, I am quite lucky of living in Italy and of living in the Western countries, say that, because as in most other Western countries, the obesity-related liver disease, so non-alcoholic fatty liver disease, or now the metabolic associated fatty liver disease, are the most frequent. Hepatitis B and C before were frequent, now are quite rare. Delta virus is mostly unknown now. And And it was starting in Italy, with the Professor Rizzetto Delta. Then it was disappearing, thanks to God. Rare liver disease are singularly rare, but they are quite frequent as a group. We know everything that, except for biliary atresia, as Livancliff was saying, most disease collectively, rare liver disease of the liver represent, say, it was calculated by the European Liver Patient Association. They range between 1 to 50,000 to 100,000 live births. The major problems we have still in Europe and in Italy is that asymptomatic hypertransaminasemia or neonatal jaundice and discolored stools, although we know that are a clue for pediatric concept liver disease, and therefore a diagnosis and possibly timely prompt therapies, general pediatricians still know them not sufficiently, and so the diagnosis may be late. We have excellent pediatric liver and GI centers, but referrals is sometimes still late.
And if I could, and that lateness has consequences. The lateness in diagnosing and intrahepatic cholestasis of pregnancy can result in stillbirth. Lateness in diagnosing biliary atresia can mean a child either needs a transplant instead of a Kasai procedure or even dies. And so please let people know about the seriousness of having a diagnosis that comes too late.
Yes, the problem of the correct awareness of this disease, they may happen also in pediatrics. They say, oh, also in pediatrics. This is quite a problem. Treatment. Many liver diseases are orphan, also in Europe and the United States, in terms of really curative treatments. Because, everybody now here knows that laboratory and the clinical researches for new therapies are not not attractive in terms of selling by the pharmaceutical industries. Moreover, there are some difficulties with the European EMA, European Medical Agency, and the Food and Drug Administration for presenting completed trial results due to the limited pool of patients. This is a major problem. So that in some rare liver disease, liver transplantation stands as the only curative option. Still, one has to understand that the goal of treatment is not only the liver disease, the treatment of the liver disease, but a better quality of life as well. So the problem continues well after transplantation, and whereas this is a major problem at all ages, especially in children, because probably we'll speak about that later on. There is the problem of transition. Yes. Most people, most children got lost in transition. There is a movie, Got in Translation, Got in Transition. Yes. This is a major problem because several adolescents have some problem to follow cures, and also we do not find the right doctors for them, and they may lose their graft or have some relapses of the treatment, such as autoimmune hepatitis, Wilson disease, and so on.
That is an important issue, and one of the reasons that we do try to use this time all year long, but particularly during Pediatric and Rare Liver Diseases Month, to think about the needs of families with young children, children in elementary, middle school, high school who just want to be like everybody else. They don't want to be sick. They don't want to take their medicines. I was diagnosed when I was 13 and transplanted, I just shortly after I graduated college. And it was very difficult to know what to share with my friends and, to have to be diligent about taking my transplant medicines, in my 20s. Was a transition. And so making sure that in children's hospitals, in that transition to adult care, in perhaps a protected transplant bubble where there's a transplant coordinator who is really following things up with you versus coming out into, I call myself a free range patient now because I'm just trying to connect myself to care. Those are all very hard when you're trying to find rare disease experts for all of your life and health conditions who understand what it means to do that in the context of transplantation. And so and you also mentioned a fantastic issue about making sure that we have the right incentives for innovation in pediatric diseases, in rare diseases. I know we have the Orphan Drug Act and there are certain pediatric incentives, but that is something that I think as a liver community, we want to make sure that, we pay attention to. Let me ask you a question about the role of non-invasive diagnostics in that development of research, particularly in children. How important is it to get beyond the biopsy, for example, and to be able to do non-invasive screening and diagnosis and treatment monitoring? Because I assume that people are even less likely to want to have a biopsy for their children than they are for themselves. So is that something that can advance research in pediatric liver research, having better non-invasive diagnostics?
Yeah, you mean the application
imaging or blood work instead of biopsy?
Yes. Now is a somewhat interesting approach. It's called liquid biopsy. Mm-hmm. Liquid biopsy means that you can look at the liver health and at the liver possible etiologic agents without a liver biopsy. Liver biopsy is invasive, is a cost, it does costs. And guess versus the previous years, we are using it much lesser than in the previous times. And this is thanks to the fact that molecular markers of etiological agents may be found with modern approaches. The same approaches may be used also, hopefully, for the treatment.
Yes.
We probably will speak about that in the post, but to say that, yes, non-invasivity is a major target in pediatric liver disorders for diagnosis. And you were mentioning ultrasonography. I would say MRI. Mm-hmm. MRI can make a beautiful work for looking at the biliary tract the disorders, say primary sclerosing cholangitis, for example, without doing any radiological invasive tests such as previous one with radiology. It may save several amounts of gray of the amount of radiations to the child, because magnetic resonance imaging is without radiations. And this is a big progress in the diagnosis of biliary tract disorders in children. This is good for Caroli disease. It is good for primary sclerosing cholangitis. It is good for choledochal cyst of the biliary tract. So we can have it as a good friend to help non-invasive diagnosis of pediatric liver disorders.
That's so important. Let me go back to our friends in Cameroon since they fought their way back onto the screen. Let me ask Madame Lainsi if having non-invasive testing, maybe mobile vans with, with MRIs or other imaging or ability to do screenings, to bring the screenings to people, to the community, would that be well received? Would that be helpful to your efforts?
Okay, with that procedure, normally in the hospital, it is not even available for, and is quite expensive if there is a liver to screen for liver disease. So if we have this invasive procedure, if they can, all it needs an approach of sensitizing and educating so that they can use it, and it will be very effective. It will be received based on the approach of educating the medics. Dr. Cliff at the beginning said we need to involve the general practitioners. So we get them, we buy them up first by educating to tell them that this is a problem. So once we get their attention, they are the ones who are now seeing the patients every day, able to get to the patients, and then they use the procedure, and it will be very effective.
Dr. Livancliff, thank you so much. That's really helpful to all of our understanding. Dr. Livancliff, is this move towards non-invasive diagnostics very important to scaling and bringing more liver screening as well as liver education into your communities?
Donna, I must say that is what will work best in our context, because we live in a context where health is still perceived in a very primitive way, and anything that will have to do with invasive procedures is not really very welcomed. That's why you see, even right now in our context, more of testings are being done using imaging and test strips and all, which is well accepted with the population given our particular context, because they feel like more invasive procedures are very risky, because one, we lack the skilled personnel for that. So they are very risky, and we might not have the human resource for people will be able to do that. And I think also, given our context where majority of the population are not hospital seeking. Why? Because like we discussed last time, it's not because they don't want to, but they don't have the means to go to the hospital and the means to get tested. Either the access means, which is in case of transportation, barrier access, or access in terms of financial access. So I think having such a move with mobile vans with testing equipment will be marvelous in such our settings, because the truth to be told, most are concerned about your health, but they don't have the means. That's why when we launch these free campaigns, the number of people who will turn out to be screened is even more than the test strips that we have, and that is the limitation. So it gives you the impression that people really want to get tested, but they don't just have the means, they don't just have that opportunity. So if we really want to build data, if we really want to gather enough information, we have to go towards a very strategic approach. Improve access to testing to the communities. While they are coming in for testing, we are gathering data that will back our public health advocacy to show that this is a problem. This is what national concern. This is what public health concern. And as Empower Women Foundation, we can take the advocacy to the policy makers to show them the burden of this problem as an eye opener for them to act. Because like I told you, the question they keep asking is, how is this a problem? Many of, especially in pediatric liver disease, many of them are hereditary. And at times, some may be asymptomatic, and many of them go undiagnosed. Many of them are not even heard. Like when you tell them what is biliary atresia, most of them will not even know, because these are things are not common. But is it? I asked myself a question: is it that they don't exist, or is it that we are not looking at it?
Right.
They exist,
exactly.
but we miss it.
Dr.
And that is,
Vajro, I
yeah.
think you want to pipe in here.
No, thank you very much, Livancliff. It was very interesting, your question, your reflection. But still, even in absence of very expensive tools, such as the universal neonatal screening with spectrometry that is able to find metabolic disorders in newborns. Among these, there are several pediatric rare liver disease, hereditary fructose intolerance, glycogenosis. There are the same PFIC and so on. There is something very, very not expensive, but just requires organization. One example comes from the Asian people with the stool card testing and with the direct bilirubin testing in newborns. It may make diagnosis very early of biliary atresia. Patient go to the Casayo intervention of the so-called hepatoportal enterostomy very early, and they can save a lot of money needed for liver transplantation and for deaths. And if you do a pros and contras for expenses of starting such very very cheap tests, well, it is very worth doing it also in countries where the financial opportunities are not so high. It is difficult in Cameroon, but it is also difficult in Italy. We have not yet been able to start with the direct bilirubin in newborns, and we are not even been able to start with the stool color card in newborns for an early diagnosis of biliary atresia. So it is a political.
I think we should take that on then. Because it's an issue that it was one of the earliest tools and best practices that I had heard of from Taiwan when I started Global Liver Institute. Talked with Kathy Schwartz at Johns Hopkins, and so I'm always asking my team, for something that works in Seattle, Salerno, and Senegal, and the stool card I think is something that low cost, really effective, empowering to parents, to people. And allowing them to make a difference on shortening this time to diagnosis. So I think if there was something to end on, which unfortunately we must, that action to move together on the stool card in all of the regions in which we work is something that I think we should move forward.
Yeah.
Thank you all for your time today, and thank you for your persistence in coming back onto the platform. I look forward to further conversations and work with you all. Before we go, okay, go ahead. Before we go,
I have still to say something about this. Our speech was about mothers and child.
Yes.
The problem is that the mother, she may have a previous liver disorders and chronic liver disorders, and during pregnancy, her liver disorders may become worse. And during pregnancy, she can have worse portal hypertension with some variceal bleeding. And so it is important to take care of these mother problems. But still, another problem is the one that we have to be sure that there is a strong cooperation between hepatologists, between gynecologists, and with the neonatologists. Because sometimes if the mother does not know that she is a HBV carrier or HCV as a HCV disease, she cannot start treatment before pregnancy or even during pregnancy, and she can not lower the viral load. And so the children, even though they make immunization, active and passive immunization, they can get, it is still possible, it is very much possible, hepatitis B when they are born, or hepatitis C, because the mother have not taken the right drug during before pregnancy. And
birth dose vaccination is a very important part of our advocacy, our global advocacy campaign. You're absolutely right.
And regarding quality of life, I would say that before pregnancy, in order to get a beautiful progeny, beautiful children, yes,
Yeah.
parents should take care of their fitness, because there is a transgenerational transmission of obesity and of metabolic syndrome to their children. And we know that this is at least in the Western country, but also now in the developing countries is becoming one of the most major problem for the non-transmissible chronic disease. So this is something that is around mother and child. And we as doctors or people that take care of the mother-child diet, we have to improve it. It is easy, but we need to do it.
Definitely. I think I'll just end by saying, I think having collaboration in knowledge exchange, it's very, very important, as we can learn from what works in other parts of the country. How can we employ it in our setting? Like we talk about the stool cards, I'll be very interested to learn more about it, and other very, very cheap and non-invasive tests that could be carried out, and that could really, really help diagnose liver disease early for children. Thank you so much. This has been really, really wonderful.
Thank you. Thank you all. Buenos Aires.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.